this case study, we will be talking about aortic stenosis. We're going to define the pathophysiology of aortic stenosis, also presenting a flow chart helping to define it. We're to discuss any treatment options of aortic stenosis, also reviewing any complications related to it. All of this will be discussed using evidence-based practices found in research. This is our patient. His name is Dr. Richard Weber. He's former chief of surgery. He's a 65-year-old African-American male. He started having some shortness of breath in the OR. While he was giving a patient CPR, he was starting to have some chest pain. There was an embarrassing circumstance where he started to feel lightheaded, but he operated, so he thought he could just push through it, but he ended up passing out during surgery. After further workup, he was discovered to have aortic stenosis. Being a doctor, he can be a difficult patient, the fact that he doesn't put his health before his patient's. These are the medicines that he is taking. He takes a baby aspirin, he takes lisinopril, melatonin, fish oil, omeprazole, metformin, and Lipitor. Dr. Weber's history includes having hypertension, GERD, hyperlipidemia, type 2 diabetes. He's had an inguinal hernia repair. He has had alcohol abuse, but he's currently in remission, and he is a never smoker. As we've talked about before, he is a surgeon. He's on his feet for long periods of time. His family history includes his father, who is living, who has diabetes, his mother, who is no longer living. She has a history of hypertension and breast cancer, and his brother has prostate cancer and hypertension, who is still living. You finally get Dr. Weber between his surgeries to go get a physical exam. You can see on the screen his vital signs. His blood pressure is well controlled with his medicines. You listen to his heart and lungs. His lungs sound clear and his heart rate is normal with a normal rhythm, but you do note a slight systolic murmur. His abdomen is soft and flat. His skin is warm and dry. He's alert and oriented ×3, and his behavior is normal, although he does have some annoyance because you are taking him away from his surgeries.
During this physical exam of Dr. Weber, we ask him what complaints he's been having within the past few months. We do this by using the 10-point review of systems. As you can see on the screen, it's broken up by each human body system. Dr. Weber says that his only complaints he's had the past few months are dizziness, syncope, shortness of breath, and chest pain. We were able to get some diagnostic tests run on Dr. Weber. One of the tests we ran were a heart catheterization. This was done to check to make sure he does not have evidence of coronary artery disease. Reason being is when we're deciding our surgical plan or treatment plan, it might also be included that we'd have to do a CABG procedure, also called a coronary artery bypass graft, on top of replacing the valve. A CT angiogram was also obtained. This was used to look at the blood flow in Dr. Weber's heart and also look at his aorta. He also got an EKG, which told us that he had normal sinus rhythm, but EKGs can also detect heart disease and dysrhythmias. We got a pulmonary function test, or PFTs. This was done because Dr. Weber was complaining of some shortness of breath. This looks at a patient's lung function. A transesophageal echocardiogram, or also called a TTE, was used, and this can help check the severity of the aortic stenosis. We also got a full set of labs, all of which were normal besides the ones you see on the screen.
So what is aortic stenosis? It is the constriction and narrowing of the aortic valve, which impedes blood flow. This in turn causes the chamber of the heart preceding it to work harder to overcome the resistance. As you can see on the slide, there are two aortic valves. One is a healthy open aortic valve, and the other one is an open aortic valve with severe stenosis. The three common causes of aortic stenosis include calcified degeneration related to aging, congenital bicuspid valve, and also inflammatory damage caused by the rheumatic heart disease. Let's talk about the pathogenesis of aortic stenosis. subendothelial thickening, which represents the early stages of aortic stenosis. It has an increased thickening of the aortic valve leaflets, which is characterized by an accumulation of inflammatory infiltrates, mostly macrophages, T lymphocytes, lipids, and oxidized lipids. Studies have also found that apolipoproteins, such as apolipo B, A, and E, also with lipid foam cells and macrophages, have been found in the early stenotic valve lesions. Macrophages, T lymphocytes, oxidize LDL proteins, which can cause the pro-inflammatory cytokines, which can then create valve remodeling and calcification. These cytokines include transforming growth factor beta 1, interleukin 1 beta, have all been found in valve matrix. They also are found to increase the local production of matrix metalloproteinases 1 and 2. All of these can contribute to cell apoptosis, extracellular matrix formation, and remodeling, which can then cause the valve to be predisposed to calcification. Angiotensin II is an important mediator of the inflammation and fibrosis. When it's formed by angiotensin converting enzyme, or ACE, it includes the mast cell-derived nucleoprotease and kinase. All of these have been found in the stenotic valve, but have not been found in normal aortic valves.
Calcification of the aortic valve leaflets tends to occur towards the later stages of aortic stenosis. The motility of the leaflets are severely restricted at this stage due to all the processes that we discussed earlier. There's also other proteins that include osteopotin and also active osteoblasts and osteoclasts. These are normally seen in the pathogenesis of bone formation. But when we find these in calcified aortic valves, studies have shown that it may contribute to the calcification of the aortic valves. Let's talk about what's causing Dr. Weber's symptoms. Angina or chest pain is caused by the heart's increased need for oxygen. When the heart muscle becomes hypertrophied, the demand for oxygen increases. The myocardium is unable to get the amount of oxygen it needs, and it causes the chest pain. The other symptom he's complaining of is dyspnea or shortness of breath. This can be due to the decreased cardiac output resulting from aortic stenosis, making it harder for the oxygenated blood to reach the rest of the body. This in turn causes the pressure of the blood vessels around the lungs to increase. This causes pulmonary edema, which in turn creates fluid to be pushed into the air spaces in the lungs, causing dyspnea. The last complaint he has is syncope. This can be caused by the lack of blood flow to the brain due to the restricted flow of blood to the from the aortic valve into the aorta, which goes to the carotid artery which supplies blood to the brain.
If aortic stenosis goes untreated, it can cause left ventricular hypertrophy and heart failure. As you see on this picture, this is a picture of a heart, and you can see that the left ventricle is quite hypertrophied and much bigger than the right ventricle. So how does this happen? Well, this happens because there is an obstruction of blood flow from the left ventricle due to the stenosis of the aortic valve. This causes the left ventricle to have an increased workload. By causing that increased workload, this causes the left ventricle wall to become thickened or hypertrophied. This in turn increases the myocardial oxygen demand. And when that is unable to happen, there is more ventricular hypertrophy. Then the supply and demand of myocardial oxygen is mismatched, meaning that there is not enough oxygen for the heart. This then causes myocardial ischemia, which and then causes angina or chest pain. Some of the risk factors that contribute to aortic stenosis include smoking, hypertension, obesity, diabetes, lipid abnormalities, chronic renal failure, coronary artery disease, and older age. So Dr. Weber doesn't have all of these risk factors, but he does have some. Having high blood pressure, hypertension, can cause the damaged cells of the valve to lose its elasticity, which can then cause the aortic valve to start to stiff.
The increased amount of glucose and lipids in the blood can activate the inflammatory system. As we talked about in previous slides, we knew that this can be the beginning of aortic stenosis. And this can also contribute to the predisposition of calcification in the aortic valves.
Next, we're going to talk about the treatments of aortic stenosis. There is aortic valve replacement, there is balloon valvuloplasty, and there is transcatheter aortic valve replacement, also called a TAVR procedure. So aortic valve replacement, this is replacing the valve, and this is an open heart procedure. There are some risks, including infections and bleeding, irregular heart rhythms, blood clots, and complications from the anesthesia. There are a couple different valves that can be placed during this procedure. It could come from a pig or cow or human. The risks with these is that they don't last as long as mechanical valves. But with a mechanical valve, these patients have to be on blood thinners for the rest of their lives.
The balloon valvuloplasty is used for patients who are symptomatic but are not good surgical candidates. It can also be used as a bridge for surgical transcatheter aortic valve implantation. This is done by the balloon being threaded through the aortic valve. Once the balloon is in place, it is inflated to create a larger opening for the new valve to be placed, or is also used to increase the blood flow through the heart. The TAVR/TAVI procedure was first introduced in 2002 for those patients who were at high risk for open AVR procedure. Study done showed that there was a decreased risk of mortality in low-risk patients with TAVR at 1-year follow-ups. On the screen, you can see the steps for a TAVR. It starts with a surgeon accessing the femoral artery. Then a guide wire is threaded up through the aorta, followed with fluoroscopy. Using the wire with a new aortic valve, it is placed in the proper spot. The valve is then expanded. Once everyone in the room agrees, the valve is deployed and the patient has a brand new aortic valve. There is, however, risk to this procedure, such as stroke, clots, bleeding, the new wire puncturing the left ventricle, and of course the scary one, death. But done correctly, this procedure can be done minimally invasive and with a short-term hospital stay. This is Dr. Weber's critical event flow chart. The risk factors that Dr. Weber has, such as age, hypertension, and diabetes, all of which could have contributed to his aortic stenosis. Also, some of the complications that can result from aortic stenosis, such as heart failure that we talked about earlier, but also stroke, blood clots, and arrhythmias. You've decided the best treatment plan for Dr. Weber is that he needs an aortic valve replacement. You've also found that he is a good candidate for a TAVR procedure, but he decides that he will only allow Dr. Christina Yang to perform the surgery. Dr. Weber decides to fly to Zurich, Switzerland to have her perform the surgery. He will have to be on anticoagulant therapy for the rest of his life. Dr. Weber knows the risks of this procedure, but he is agreeable to our treatment recommendations.